So, hello and welcome to tonight's conversation. I'm very sure that you either may have known somebody or you may have read or heard that somebody has taken their own life. And issues pertaining to suicide are not very easy to discuss, they can be very daunting sometimes. So, as you join us, please tell us where you're watching us from. Also, tell us if our sound is good, and also allow me to take this opportunity to thank and appreciate our sponsor for tonight's program. And this is none other than CarePeak Specialist Clinic. CarePeak Specialist Clinic is located in Rhodes Park, area of Lusaka along Omelo Mumba Road. And CarePeak Specialist Clinic handles all manner of medical conditions. So much appreciation for all to CarePeak for affording us this opportunity. So, welcome once again, and I've seen that we're joined by people from Kenya. You're welcome. I've seen that there are some from Nigeria, South Africa as usual, and Namibia. You're always here. So tonight I'm joined by again Dr. Dalao. Let me just bring him in so that we can. Yes, Dr. Dalao.
Hello, Dr. Mujajati, and hello, everyone.
How are you this evening, my brother?
I am well. How are you? I'm glad it rained today.
Okay. Yeah, I've been indoors all day, and straight from the practice, I came to prepare for this program. So I haven't seen much of the outside. It's good to hear that it rained.
Yeah, I'm very happy it rained, and I just enjoy the smell. I keep forgetting the name, but I'm very happy that it drizzled today in the evening.
Right. So, Dr. Delau, very quickly, I know that there are some here who interacted with you last time, and although there could be some who are seeing you for the first time. So, could you just quickly introduce yourself?
Yes, so my name is Dr. Naeem Dalal. I am a psychiatrist, which basically means that I'm a medical doctor who has specialized in brain health, in particular the mind and functioning part of the brain. And I am practicing with the university teaching hospitals as well as at peripheral hospitals within the country, strengthening mental health systems in the country. I have, before I was a medical doctor, I've had over a decade of experience with preventive health advocacy as well as mental health advocacy. And that's basically about me, Dr. Mujajati.
Right. And talking about advocacy, I know that you are part of a community health group, a mental health group for prevention and promotion of mental health called Ganizo. Could you just, tell us and the listeners and the viewers on what that project is about before we delve into our
Yes.
subject?
Yes, so Ganizo is a public service organization. What that basically means is that we are serving the communities in understanding health and well-being, in particular to do with mental health. Now, Dr. Mujajati, when we talk about mental health, there are a lot of conditions that we don't know in our local languages. For instance, what do we call depression in our local language, or even the brain and how the brain functions? What words do we use? How do you communicate that to a lay person right here in our country? So this is how over the course of the years, as I've been going out in the many communities, both rural and urban here in Zambia, I found that there is that mismatch in understanding. So a few good people decided to start calling me Dr. Ganizo because nikaenda mumakombo I just start talking about emotions and well-being, and then they just say, oh, you're talking about thoughts and this is what you mean, and they put things together. And so we are trying to narrate neuroscience, brain health conditions in local languages. So that birthed the organization called Ganizo Zambia Initiative, where we are talking about mental health and brain health conditions, but tailoring it to local culture and beliefs. And that's how we are creating awareness and spreading the messages of prevention in mental health and well-being.
Right. No, thanks, doctor. So tonight we are discussing suicidal thoughts and completed suicide. We're also going to issues of self-harm and try and make sense of it. Very quickly, doc. Very quickly. What is suicide?
Okay, so suicide is simply the act of purposely ending your own life. And this is just basically saying that when you have a thought of not wanting to leave, then that is also known as suicide, but that is called passive suicide. On the other hand, when you actually carry the act out, that is when you call it a completed suicide. So, suicide is the act of purposefully ending your own life, and society views suicides by culture, religion, and circumstances under which they occur. So, there's also the concept of suicidal ideation, which is when one has a thought of suicide but does not want to carry the act itself out. So that is what we call suicidal ideation.
Right. Doctor, very quickly, are there different types of suicide?
So, based on the previous point, yes. So, when we talk about passive suicide, we're basically talking about someone who has the thoughts of not wanting to leave and constantly having these thoughts on repeat that I don't want to leave. I can't go on like this. I want to stop leaving. So, that is what we call passive suicide. They may put certain actions and plans in place where they will do this or they will do that to, formulate that particular thought, but they won't carry that act out. So, we call that passive suicide. Then, on the other hand, active suicide is where this person who has these thoughts of not wanting to leave actually goes ahead and plans it out, writes it down, writes a will, tells friends and family around them to say, I'm not going to stay for long. So, if I was not around, make sure you do this, or you tell this person so and so. And so this is actually active suicide. So these are the two different terms that we usually talk in when it comes to passive and active suicide. And of course, I mentioned already suicidal ideations, where someone wants to die but does not really have the willpower to actually do it. So just to add a few things in terms of types, I would also just like to add a few statistics, Dr. Mujajati,
Go
where
ahead.
there's actually in the world right now we have over 800,000 people that die by suicide in a year. So that's literally every 40 seconds that's passing by, one person is dying by suicide. So that's huge. Every 40 seconds of a minute, a person is dying by suicide. And suicide is actually the 15th leading cause of death globally. So in numbers, it's in the top 20 and it's at number 15. And also, suicide is the leading cause of death in people aged 15 to 24. So again, Dr. Mujajati, we're talking about the young ones, the youth. In the age ranges of 15 to 24 to 29, it's actually the leading to second leading cause of death. And then finally, it's actually very common amongst older adolescents, especially in young girls. And it is the second leading cause of death, including in sub Saharan Africa amongst adolescent girls. So, to speak about the statistics and the types of suicide, it is very prevalent and very common.
Hmm. I'm glad you went further to address the issue of numbers and how big the problem is, and at the global level. And I want to suspect that the problem is quite similar here in Zambia in terms of numbers.
Yes, Dr. Mujahati. So when we come to our country here, right here in our practice, every other day you'll see in the emergency room that there is a person that is brought in with an act of self-harm, or someone who did not want to leave and maybe took in battery acid, which is a very common cause, or someone who tried to, take rat poison or insecticide. And I would like to make mention and give a shout out to an African country called Nigeria that actually banned fertilizers, over the counter use of fertilizers, because they noticed that that was a common way in which people were actually using to uh, um, take their own lives. Other than that, we also see a lot of individuals that come in emergency casualty where they drink and drive, and a few of them actually drink excessively so that they can be in a road traffic accident so that they can take their own life. And these are things that we are not very quick to probe as healthcare workers, because with us, we tend to focus in our discipline. For instance, if you come to casualty, I will make sure that I will stabilize you in terms of if you're bleeding, if you have a fracture, then that's what I'll focus on. Similarly, if you come to the ER in physician, a male, adult medical, I'll quickly be able to make sure your vitals are stabilized and then have that conversation with you. So if you were to do a survey in our country, I will assure you that at least on average, we do get one or two every other week or every day. Then, speaking of our own lifeline here called 116, according to their statistics, they do get individuals that have thoughts of self harm every other day. They do have at least one caller who calls in to say, I do not want to leave. And then coming to me as an individual, my practice every day, for me, this is my service, literally. I have situations where I have clients who are every day telling me to say, Dr. Dalal, I don't want to leave. I can't go on like this. I want to, die. It's very, very common. And then when we also talk about just social media and inboxing or amongst friends and family, every friend or every network knows that there's someone out there who has mentioned in passing to say they can't go on and they don't want to leave right here in our country. So it's not far-fetched, it is very common.
Hmm. Right. Doctor, is suicide a mental health disorder?
For this one, Dr. Mujajati, there's a two prong response. What I mean by that is not all suicides are mental health related. So suicide is actually a symptom in mental health. When we say a symptom, it's something that it presents with, a person can present with. So there are certain severe emotional reactions in which an individual may respond in a way that they may feel overwhelmed and may harm themselves. That does not necessarily mean that they want to die. It just means that they are using that moment that is exposing them in reality to react in that way. I would like everyone to think about the emotions. Anger, for instance, whenever we are angry, we respond in a way that is very overwhelming to us. We may say things, we may do things, we may act out in certain ways, we may harm others, we may insult others. But when that anger emotion goes down, we kind of realize that that wasn't what we meant, and we somewhat realize and come to an affirmation that, okay, I did not mean that, or I did not want to do that. Similarly, sometimes when an individual is overwhelmingly sad or overwhelmingly irritable or anxious, they may actually carry the act out of self harming, not necessarily with the hope of wanting to die. So that is not mental health related. That is clearly more of a lapse and emotional storm that we speak of. Then, on the other hand, we do have suicide, which is a symptom of mental health conditions such as clinical depression. Clinical depression is a condition which falls under the mood spectrum of disorders where an individual feels very low for a very long period of time, for over weeks or days. And apart from feeling low, they have very low energy. And in addition to these two, they also have loss of interest in their day to day activities. They feel guilty, they feel hopeless, and they feel like they cannot do anything. Individuals who have clinical depression can end up having suicidal thoughts. And the reason behind, Dr. Mujajati, is because it's not just in their head, it's actually the brain. The part of the brain that is responsible for making you feel happy and content, that produces a neurotransmitter known as serotonin. Now, serotonin is responsible for your happiness and uplifting you and taking you from day to day life. Now, this is depleted in the brain. And because that is depleted, this person doesn't have the energy, the zeal, and they feel hopeless and helpless and may not want to leave. And they have suicidal thoughts and they may carry the act of suicide out. So, a person who is clinically depressed has a higher risk of actually completing the act of suicide out. Now, here's another thing, Dr. Mujajati, about clinical depression. Now, because a person who is clinically depressed is feeling low, this person also doesn't have the energy because the brain doesn't have the ability to help you with the energy. So, because they don't have the energy, they may have the thoughts of not wanting to leave, but because they don't have the energy, they won't go ahead with that act. But the minute they get little amount of energy, they will carry that act out. So sometimes individuals who are clinically depressed may carry the act out of harming themselves, but may not go through with it because they don't have 100% energy to complete the act. And in that moment, if we don't come in and help these individuals, and we start labeling them to say, no, this is attention seeking, then we're actually making it worse, because that's the window period where we can actually support them. Other than that, Dr. Mujajati, there are other mental health conditions such as bipolar mood disorder, where there are extremes of moods. You are high, very excited easily, or you are low, very low at the same time. So even individuals who have bipolar mood disorder, which is a very common disorder in our country, here in Zambia as well, they have a three times likelihood or risk of dying by suicide. Then there are other mental health conditions such as schizophrenia, which fall in the psychotic frame of mental health conditions. These individuals also live normal lives, but because of hearing voices or seeing things that are not there, they also are at a higher likelihood of dying by suicide, because they may carry the act out. Then we also have other conditions such as anxiety spectrum disorders. Individuals who also have anxiety spectrum disorders also have a higher likelihood of dying by suicide. Then there's also substance use disorders, Dr. Mujajati, such as alcohol use or other substances such as opioids or cocaine, where individuals that use these substances may actually die by suicide in an act of overdose, or maybe just feeling overwhelmed. So, to answer your question, not all suicides, completed suicides, are because of mental health disorders or underlying mental health condition. In most cases, they are not even mental health related. It's really the emotional reaction or the emotional storm that they are going through.
Mm. Having said that, doctor, so what are the risk factors of suicide?
Okay, so with risks, we often look at what is it that would predispose a person to that thing. And now in this case we're talking about self-harming. So they vary with age as well as gender and ethnic groups. When I say ethnic groups, I'm talking about tribes and backgrounds. But some important risk factors are mental health conditions such as clinical depression or bipolar mood disorder or generalized anxiety disorder. These are things that people need to be aware of in themselves. Then there's also substance abuse. This I can't stress enough, especially in our country where we take alcohol as a social habit. It has been known that it can also be a gateway to, having thoughts of not wanting to leave and guilt. Then there's also prior suicide attempt. Now, this is something that people need to understand. If someone has tried to attempt an act of harming themselves, then there is a higher likelihood that they may actually do it again. Then there's also family history of suicide. Is there a family member or a family history of suicide? Then that is important to know, because certain mental health conditions run in families, so it's very easier to pick up. Then there's also past history of family violence. Again, we are commemorating gender-based violence days now, and just so you know, GBV is actually a risk factor to self-harm. Also, physical and sexual abuse in the past. This is why it is one of the hypothesized reasons why suicide is the leading cause or second leading cause in adolescent girls, especially in sub-Saharan Africa. It's because of sexual molestation and abuse that young girls face in our vulnerable girls face in our communities. Then there's also easy access to things that can be used as a means of harming oneself, such as firearms or in insecticides or fertilizer, or things that people can easily Google or know in their communities, such as battery acid that they can take, that they can use, because in that moment it's a spur of a moment. Then also when you're incarcerated in the law system, there's a lot of self-harm and suicide that takes place in the justice system as well, because of the nature in which individuals are put there and the many factors that come with it. And then also there's exposure to suicidal behavior of others, such as family members or peers. And this is where I'm going to bring in this statistic, Dr. Mujajati, that we have to be very sensitive about things like suicide. Reason being, did you know, Dr. Mujajati, that according to scientific and behavioral studies, for every one suicide that is completed, 25 other people in the network, in the community, will think or are thinking about it. So if I am one person who dies by suicide, it means 25 people who are around me, it could be online, it could be in my real life, will actually think about it or are thinking about it. So which means it's like contagious. One suicide will make 25 other people around them think about it. So it's very important to know that a suicide that's happened in itself is actually a risk factor, no matter it being something that you've just read online, or it's just on the radio or on the TV. It in itself is actually a risk factor that can predispose to other suicides as well.
Hmm. So, which brings me to this question, Doctor. Are we able to tell, or are we able to predict whether somebody may or is likely to, go and, uh, involve themselves in acts of suicide? For example, what are the signs, what are the symptoms of somebody who may go ahead and uh, and and complete the act of suicide?
Yes, so there are certain things. Of course, everyone is unique, everyone has their own identity, but there are certain ways that we can actually help or check if someone may have thoughts of not wanting to live. So, the signs that you might notice in yourself or friends or anyone around you, and you should be concerned, include talking about wanting to die or to kill oneself. Sometimes people jokingly say it, but in the field of mental health as professionals, we say there's no such thing as a joke when it comes to not wanting to live. There's so many times I've read on social media, even on Twitter or just on Facebook, where people say, no suicide thought, but I wish I could pause life right now. Clearly that's coming from a very deep space, and that may be a sign that you need to probe further and probe in a sensitive manner. Looking for a way, another point is looking for a way to kill oneself, such as searching online or buying a gun or checking how many pills do you need to actually take so that you will actually die. That's another thing. Talking about feeling hopeless or having no reason to live. And we see that a lot, especially with the current uncertainty with the COVID-19 pandemic. People say, there's nothing to live for. What do we have? So these are things that shouldn't be taken lightly. Talking about feeling trapped or in unbearable pain. Now, pain, people always think and perceive, Dr. Mujajati, that pain is physical in nature. But people don't understand that the organ that is responsible for triggering these pain receptors is the brain. And if you're thinking about pain can manifest itself psychologically as well. So that in itself is also something to ask about, or if someone is talking about it. Then talking about being a burden to others, and this is a very big one. Oftentimes we look at people who do share that, no, I don't want to be a burden on someone else, no, this is why I'm doing this, this is why I'm doing this. And they have that personality, they want to be independent, but at the same time they don't want to ask for help. This is something that should also make someone think and ask and probe. Then talking about increased use of alcohol or drugs. Clearly, that's a change in habit. And if it's sudden, then you need to look into that, because they may be feeling hopeless, helpless. And, alcohol in itself is a drug to the brain that helps with certain moods and emotions. And the GABA receptors, which I am aware of as a professional. So again, when someone's drinking and drug taking behavior suddenly changes, then that's of concern as well. Acting anxious or agitated and behaving recklessly is another sign that people need to look out for. Maybe they're not using their usual way of communicating, or their routine has changed completely and they're becoming irritable. Then that's another thing. Another way to look for suicidal risks is also changes in pattern in sleep. Maybe they're sleeping too little or they're sleeping too much, because the brain's wake and arousal and sleep pattern is disturbed. So that is another thing that is a good point. And then also, people who are thinking of not wanting to leave will also start withdrawing themselves or feeling isolated. So they'll start withdrawing themselves. And today, in the era of social media, they may also start posting on social media to say, I'm not happy anymore. I feel hopeless. I may not see another day. Sometimes people will think that it is attention seeking, but there is a lot more to it. Showing rage or actually talking about seeking revenge. This is something that's also the bargaining with spiritual self or spirituality to say, why is God doing this to me? I'm going to make sure I get revenge about this. Or when they're wronged due to something, they may start saying these things that I don't care what happens to me, I'm going to go and get my revenge, and if I have to die, I'm going to die. And then also, there's just these swings in moods in individuals that may have thoughts of not wanting to leave. So there are many ways that one can actually see a pattern that this person may not want to leave. And the best people are the people that are close to them, their loved ones, or the people that surround them. They will be at the best position to help know that, okay, I think this person needs help.
Right. Doctor, in your practice, what are some of the myths that you've heard or that you've come across about suicide?
Okay, Dr. Mujajati, for me, the first one, and it's not a myth, but I'm going to be as sensitive and as candid as I can. It's to do with religion. Dr. Mujajati, we are a religious country. I too, the religion I practice is also very dear to me. It's one of the values I hold very dearly. Now, when we say that suicide is a sin, then we don't
Mhm.
talk about it. How are we helping? And this is one of the concerns or biggest barriers and limitations that we have when we have to talk about Nkania suicide. Talk about suicide is a big issue when it comes to religion, because religion says it's a sin and you will be in limbo. You will, God will not be happy with you. And that's very true. And that's what religion says. But then if it is a sin, what are we doing about that sin? Are we not supposed to try and prevent it? And if so, if we are preventing the sin from happening, are we not practicing um, religion? And this is the biggest thing that I feel is also something that needs to be talked about and communicated. In houses of prayer, we need to have these conversations to say we have a lot of us that are battling these thoughts of not wanting to leave, and that doesn't mean that they are sinners. At that point, we need to help them so that they overcome those thoughts, and so that we actually practice religion as a whole. And when we start quoting scriptures such as, God won't give you anything that you cannot handle, God has given you more than you could have handled, and you've transpired so far. All these things are very, very true, but that also needs community and support. Having that said, Dr. Mujajati, this is where I come from with my practice of suicide prevention. I look at it, even as I look at it from a lens of religion, I look at it as a lens of practicing it and promoting it by helping people who are having these thoughts and get over them and live healthier lives. Now, coming to myths, Dr. Mujajati, the biggest myth is that the person who has suicidal thoughts has been bewitched and has been possessed by the demons, and this is very common in our practice. And this is why even when they bring someone to practice, the first thing the family will say, we tried everything. And when you say, what did you try? They say, no, we took them for prayers, we took them to the witch doctors, we did all sorts of fasting, we traveled with this person, but it's still not working. So that's a myth. It's very unfortunate, because that's maybe an underlying mental health condition, or maybe a severe life stressor that needs support. So that's the first myth that I would like to say. Then there's another myth that says that there is a clear reason for every suicide. People think that every suicide that has been completed out there is a clear reason. That's not true. The truth is that suicide is very complicated and involves many factors, some of which the people may have never shared or understood themselves. So no two suicides are the same, Dr. Mujajati. Then another myth, Dr. Mujajati, is that suicide means weakness. If you have thoughts of not wanting to live, means you are weak. The truth is, suicide has claimed many lives of individuals who have shown bravery throughout their lives. It is not about being weak, and it is not, to do with how weak you are. It's really about how you're going through life and what your brain is doing in that moment. Okay. Then there's another myth, and this usually happens from people that are distant to the person that has died by suicide, that suicide is a selfish act and an easy way out. um, Many times the person believes he is actually helping friends and family avoid suffering due to themselves, you see. And I say he here because according to statistics, more men die by completed suicides than women. More women carry the act of suicide out, but they don't succeed. On the other hand, men that carry the act of suicide out are often completed because of the means and lethality that is used. So oftentimes men think that, suicide is a selfish act and it's an easy way out. And that's not true. And this is another myth that needs to be taken away. You are not a burden to anyone, so please don't think like that as you're taking that act out. Then, Dr. Mujajati, there's another myth that, suicide attempts, especially in young ones and adolescents, who say suicide attempts are about seeking attention. And this is what older people think when a younger person will talk about suicide, you know. And this is where it's a myth, complete myth, because many times a person that is actually carrying the act of self-harm out is a signal for help. It's literally saying that I need help, I am in pain, but I don't know what to do. I'm emotionally overwhelmed. And other times it's like escape from attention. So this is something that adults need to understand. When children or adolescents are cutting themselves, it's basically a way of them helping them feel their psychological pain because they can't feel anything else. And also to my fellow professionals, as well as my religious fraternity, whom I respect dearly, the myth is that talking about suicide will only encourage it. That is a myth. When framed in terms of recovery, treatment, and hope, discussing suicide is one of the most helping things we can do. And many people do not know who to speak to. So we need to change that myth that, talking about suicide equals we are promoting it. No, that's lies. Then also, Dr. Mujahid, I'm happy that you asked earlier to say is suicide a mental health issue or concern. It's a myth. People think that only people with mental disorders are suicidal. The truth is, suicidal behavior indicates deep sadness and unhappiness. And deep sadness and unhappiness can happen to anyone with or without a mental health disorder, because we all have mental health. But mental health is different from mental illness. And then also another myth, Dr. Mujajati, is that some people who are very unwell, for them, suicide is inevitable. Like that's just the end game for them. But that's not true. Individuals have made it back from all levels of severities of depression. So people need to understand that as well. And also, um, once a person is suicidal, it means that's it. It's like they cannot get better. That's not true. Many people have had thoughts of not wanting to leave, may have had carried the axe out, but later on have grown stronger and better. So that is also very important to know. And of course, we've discussed the risk factors and warning signs that, people, majority of suicides have warning signs as well, because people think that it just happened, we didn't know about it. If you really look, the warning signs are there. So these are the many myths that I actually see in my practice, and it's very unfortunate because for us in practice, a loss by suicide is actually a mortality that we take very hard.
Right. Talking about you in practice, how then do you treat suicide?
So treatment with suicide has to do with the basic assessment and um, support structures. So, like every healthcare worker, when you come through, it depends on at what level you've come through. But we start with a history taking where we need to create a therapeutic alliance. Therapeutic alliance means that we need to make sure that we as healthcare workers are understanding who this person is and why they've come through and what led them to take the act or action or thought that they have. We can't start with why did you do this, you don't love yourself. No, it's more about creating that rapport and that therapeutic alliance. So one of the things that we use is what we call the biopsychosocial, biology, psychology, and social part of the treatment. In biology, we are looking at the genetics in history. We are asking all these questions to say, um, do you have a family member who has carried this act out? Is there someone in your family who has had similar thoughts or processes? Do you have any underlying conditions, both physical and mental? Are you going through any stressors or risk factors in your life that has made you think of carrying this act out? What is it that's making you feel the way you feel? So there's a whole history taking, which may take anywhere from 30 to 45 minutes, where we're really trying to understand this person. And sometimes in that moment, Dr. Mujajati, the person may not be comfortable talking. So we usually also have prompt cards, where we just say, if you pick yes, just pick this card. If you say no, just pick this card, so that we can create this motion going, so that we can support this person. And then from there, we carry out an examination. In examination, we do a thorough head to toe examination. We are looking for signs of any harm to the person or themselves that they may have carried out. If the person has any scars or previous scars, we will know that this is not the first time this person has done this, but it's something that the person has often been doing. If the person has, drunk battery acid or taken pills, or has done anything that has harmed themselves, will quickly run and emerge in an emergency and overcome that. If the person is still suicidal and emotionally overwhelmed, then we'll take them through what we call de-escalation therapy, where we will understand the person and calm the person down in their own will and support and understanding. So apart from that, we will also carry out certain investigations, blood tests, run everything, so that we know that this person is not under the influence of anything at the time as well, including a blood urine analysis that will be done, so that we are able to check if there are any drugs or some substances in the system. If the person has taken any drugs or overdosed, then we will also check their profile for the liver and the kidney as well, so that they are supported. But if all these things are fine and the person is physically stable, then psychologically we are going to have a conversation where we are going to support them through it. Immediately in that moment, if they're psychologically overwhelmed, then we are going to help them with what we call containment therapy. What that basically means is that we will help the energy levels up, but we will sedate them for some time. Sedation simply means that we will want them to rest for some time, because they have gone through a traumatic experience that they may not be able to cope with. So in that moment, we will help them sedate, calm them down, and then later on take this conversation up. In treatment, further, we will also try to look for underlying conditions. It could be physical in nature, such as a chronic health condition that may lead them to think the way they do, or it could be mental in nature. So we'll try to screen for that as well. We will include the family and friends, so that there is a good support structure, because we do need this. If a person does carry the act out, it does not mean that's the first and last time. There is a risk of relapse, so we need to carry out a treatment plan that includes suicide surveillance. Suicide surveillance basically means, Dr. Mujayati, where we need to make sure that the person has the next of kin whom they trust and is with them most of the time. So this is, in a nutshell, how treatment is carried out. So it includes treatment with medication, it includes treatment with investigations, it includes treatment with family support, and it includes treatment with continuous therapy.
Right. So now, could you address someone who is at home, who is probably thinking to themselves, I have a loved one or a relative around me who I suspect could be having these problems that Dr. Dalal is talking about. So, what should individuals do to help the person who is at risk of self harm or suicide?
Okay, so if you are at home right now and you have someone who has thoughts of not wanting to leave, the most that you can do is you need to communicate with the person. Now, when I say communicate, doesn't mean you start knocking on their door or telling them to say, "What is wrong? Talk to me. I need to know what's wrong with you." No, no, no. You simply tell them to say, "Look, I'm sorry that you are feeling the way you're feeling, but I want to understand you because I want to help you. So please allow me in so that we can talk." And if the person still refuses, then please take that person to the nearest healthcare worker so that they can be supported with psychosocial counseling. But if a person agrees to say, yes, this is how I'm feeling, I am overwhelmed right now. For instance, I had every day, Dr. Mujajati, I receive text messages on my social media, be it Twitter, be it Facebook, to say, I don't want to leave. Please help me. I don't know what to do. I usually help them understand and ask themselves, what is it that's causing them to feel the way they're feeling? So these are things that you start probing. You ask them to say, okay, why is it that you don't want to leave? What led you to this thought process? When did you start thinking like this? If you were going to not leave anymore, have you thought of a way that you're going to, end your life? I know these are questions that may be very sensitive, and to you as well, you may be like, oh my God, I can't ask a question. I can't ask my brother, my sister, or my uncle, or my aunt, or my friend, how are they going to kill themselves? No. By you asking these questions, you're having that honest and candid conversation with this person who really is thinking through this. So you're literally asking them to say, if you were going to do it, how would you do it? And okay, if you were to do it, do you really think that you would be successful? And if so, how, at what time, and when are you going to do this? Okay, have you planned it? If so, okay, all right. So you have that conversation with the person, but at the same time, constantly reminding the person to say, I care for you and I want to be there for you. I can only imagine what you're going through. I cannot understand, but I want to understand and I am here for you. This actually creates that room. And the more you allow this person to keep talking about it, you will come to a realization, Dr. Mujajati, that this person is really not looking forward to die. They are stuck and they are feeling hopeless and helpless and they need support and guide. And once they understand that you are willing to offer them that support and guide, that person will open up to you and start being more free with you. And who knows, you will be the person who will support them and bring them to a healthcare worker who will guide them. Maybe through guidance, we realize that maybe the person is having major depressive disorder or has bipolar or has anxiety, and maybe that person will be treated for that and will feel better with time. So, Dr. Mujajati, for someone out there at home who has a friend or family member who is having thoughts of not wanting to live, a conversation is key, and having a conversation as openly without any judgment. Not if this thing whereby you want to kill yourself, mulungu, this, God is going to, no, God doesn't like this, no, you're not serious after all we've been through, after all we do for you. That doesn't work in that moment. I know it's hard, but we really need to do the sensitive conversation bit of it.
Right. Having said that, doctor, where would one get the help that they need regarding suicide in Zambia?
Okay, so in Zambia, Dr. Mujajati, healthcare providers, I would actually say that go to your nearest healthcare providers and ask them and be as frank and candid as possible to say, I have thoughts of not wanting to leave. I want to be supported by a mental health professional. If your health clinic has a mental health professional, you will be linked to them. If not, you will be referred to the nearest hospital that has a mental health professional. Unfortunately, it may be a journey because our mental health system is still lacking. We still have a lot of work to do there, but it is improving. If you want immediate support, then please call 116. I will repeat this number, call 116. This is a toll-free line. It's called Lifeline Zambia, and you will have trained psychosocial counselors who will be there to support you and to listen to you. I can assure you, because I have personally worked with them, facilitated, and trained them. They are very good, and I have gotten very good feedback. So if you want immediate support in a crisis, then please call 116. But otherwise, if you need in-person help and support, then go to your nearest healthcare center and be open. Just say, I would like a mental health professional, I have a psychosocial concern, and they will guide you. If they don't have, they will refer you to the nearest system in the healthcare industry where you will be referred to.
Now, Dr. Delau, some people may be scared to call. You discussed the issue of myths surrounding suicide. Is suicide or attempted, or whatever the case may be, a criminal matter in Zambia? Can someone be arrested for suicide in Zambia?
Dr. Mujajati, with our Mental Health Act, which is now, as of 2019, the Act of Parliament, suicide is not a crime. Self-harm, yes, it is a notifiable act that is notified to the police. And this is just for safety in the sense that it's a risk to oneself. So because of that, it is notified, but the person will not be held accountable. If a person is suicidal or carries the act out, and if the police are notified, the police are simply going to come through and see to it that the person is safe, is being assessed, and the assessment will guide further. They will not be held accountable to that.
So the involvement of the police in this matter has nothing to do with arresting the person, but to actually help them and give them the help that they need. And the police are there for safety. I'd like you to emphasize that.
Yes, Dr. Mujajati, police are there for safety. In an ideal environment, the police are supposed to provide that safety by taking the person to the healthcare system, where the healthcare system link them with a professional mental health care provider. It may be a clinical officer psychiatry, a mental health nurse, or a medical doctor, or a psychiatrist who will then further guide. But it is not for them to actually arrest this person and put them behind bars, because it is not something that is equitable. But unfortunately, as you are aware, Dr. Mujajati, our systems are still lacking. So there is a lot of room for improvement. But I would like to emphasize that no, it is not a crime.
Right. Doctor, another aspect that is very important in creating public awareness is the media. I'm sure you've looked at different articles in the press regarding suicide. What's your comment on the media with regards to suicide?
With regards to suicide, Dr. Mujajati, the statistics that I shared to say for every one suicide, for every one completed suicide, 25 other people are thinking about it, or 25 other people will actually carry that act out. Which just means that an article or a newspaper or even a tweet or even a Facebook post or sharing about suicide means that there will be 25 people that may be at risk. So media are a key stakeholder in the sense that they need to promote information about suicide that is not sensationalized. What do I mean by sensationalism? Sensationalism is basically sharing a story because you want likes, you want, hits on your page or in your newspaper article or your series, but you're not really getting any value out of it per se for the citizens out there. I believe as health policy, one of the health policies should be certain behavioral statistics such as suicide need to be banned from being reported by media houses if they're not going to create create a system that is going to be supportive. According to the World Health Organization, Dr. Mujajati, there are manuals and workshops that are supposed to be carried out amongst journalists so that they can actually give the correct information when they are sharing a suicide article or an information about suicide. It should not have gory details of an individual that has died due to suicide, because you will always read the article which will be sensational to say men killed by wife, man did this, man did that, woman did this, and the next thing will be, the details will be Naeem aged 20 something from Ibex, hurt himself using a knife, first cut his arm, then cut his neck, and then went on to die at the porch of the house. They will literally write everything, and then they won't even end by saying, they will just put a sensational point to say that happened after an argument with his partner. And then people out there will think that that is the reason why this happened, not knowing that the reasons are many. And then they won't even put a point at the bottom stating that should you or anyone around you have thoughts of not wanting to live or have suicidal thoughts, please reach out to so and so or visit your nearest healthcare center. So this is why the World Health Organization has clearly guided on certain things. And I believe even us as a country, we need to follow that, especially in the day and age of social media today, where we see a lot of social media articles. Just a few weeks ago, I saw a young girl's photo hanging from a tree where she had died by suicide, and people were busy sharing it far and wide. That is very insensitive, because another point, Dr. Mujajati, is in as much as for everyone's suicide, 25 other people are going to think about it or carry that act out. Did you know that every death by suicide is a death of a loved one? And over 100 to 200 people are bereaved by that death. So, because we are sensationalizing this death, we are taking away that grief from that family to grieve in peace. We are not allowing them to mourn their loss. Okay, so we're actually further stigmatizing a whole community, a whole family. So we need to, I'm glad that you ask about the journalists, because they are a key stakeholders in this preventive measure against suicide.
Right. Doctor, the other issue I need you to look into is from a medical perspective. As medical service providers, as Ministry of Health, as the healthcare system in Zambia in general, what are we doing as a country about suicide from the medical perspective?
Dr. Mujayati, I feel for the past few years, we have been creating more awareness, more radio and TV conversations are happening about suicide and self-harm. We are also creating more understanding and awareness within the healthcare industry, because suicide and self-harm does not know any profession. It doesn't take away from any profession, because in the healthcare industry as well, we have our own fair share of suicides. So there is a lot more awareness being carried out. But in terms of putting in infrastructure and resources in place so that people can get easy access to it, we have a long way to go. I would like to tailor suicide to the Mental Health Act. We have a fully active law, legislative act of mental health, which is yet to be actualized. So we have a lot of work to do, but we are slowly but surely getting there. I believe that there is room to expedite or make this quicker, but we are doing the best that we can with the available resources. In my opinion, Dr. Mujajati.
Right. So, Doctor, as we wind up, what is your take home message? What is your final thought to people who are listening to us right now? If they should forget everything we've said about suicide, what is the final nugget that you want them to take home with them? What's your take home message, Doctor, regarding suicide?
Okay, so for me, I'm just going to tell everyone, once in Zambia, you just need to understand that suicide is real. It's not something that's just in your head. It's not something that you can just forget and leave out. It's something that you need to cope with, and it's something that you need to feel. If you have thoughts of not wanting to leave, it's normal to have these thoughts. What is not normal is constantly keeping them to yourself and not trying to overcome them. So, with that said, please, if you feel overwhelmed, listen to this conversation and reach out to a healthcare worker so that we can support you. We have a lifeline where you can get immediate support, 116. As far as healthcare professionals are concerned, we are trying our very best to bring you the best services available, because you know what? We want to make sure that we bring about an environmental support structure. I hope with Dr. Mujajati's support, we will also reach out to many, many other journalists so that we can get the correct information out there. But to me, as a mental health expert and Zambia's friendly neighborhood psychiatrist, I'm going to say, we've got you. Suicide is not something to be a taboo and a sin, but suicide is preventable, and we're going to win this. Thank you.
Thank you, Dr. Delau, and thanks for coming back. You promised that you would come back, and you made it. And on behalf of the people who follow this page, I'd like to thank you most sincerely and most grateful to you for making the time, Doctor. Do take care.
Thank you.
So, ladies and gentlemen, there you have it. Thanks to CarePick Specialist Clinic, who are the sponsors of this particular segment. And tonight we were hosting Dr. Delau. And like you noticed, we were discussing issues mental health, but specifically, we were looking at suicide. Like Dr. Delau mentioned, if you are harboring any suicidal thoughts or suicidal ideation, there is help. Dial the toll-free line, which is 116 116, and there'll be somebody at the end of that line who will be very eager to assist you and talk to you and walk you through and help you. So seek help before you give up. Like I said, until next time, do take care and enjoy the rest of the evening.